after delivery, I delivered at 2. The baby was taken immediately to the NPU. So I actually didn't even know. But I had a question. The mother we were with during the delivery room, she was given her baby. I was not given mine.
Kuna kitu moja ili happen na nikafeel kwangu ni mbaya. Ile time mmetoka kwa penye mnalala kama mama juu mko different rooms na watoto wenu, alafu mnaenda kuna siku tulipata watoto wawili wamepass. Hiyo iliniumiza moyo kabisa, iliniumiza.
Baby should be taken like persons, people. When a bus have an accident and we lose 20 persons, it is highlighted in the media, it's highlighted in everywhere. But when babies die, it's like mortality is 12%, it's 17%. But these are persons. These are persons who could become teachers, who could become professors, who could become, if they were given chance. So every baby in Kenya should be given a fighting chance.
The neonatal period is one period where, in fact, now about half of all the people that will die, or the children that will die before the age of 5, actually now die in that first month of life. And actually, if you look at that half of all the deaths of under 5s in the neonatal period, 75% occur in the first week. And of those that occur in the first week, a large number occur on the first day of life. So the neonatal period has always been important, but as we've done much better at improving the survival for younger children and infants, particularly with vaccinations and better access to healthcare, the neonatal period has remained a real challenge.
A newborn is perhaps the most fragile person in terms of rapid deterioration into death in a matter of seconds. It's basically because they're born transitioning from a uterus, a womb, which has all those nice facilities. There's a placenta looking after them. They don't have to worry about that. There's the water from the mother that is also keeping them warm. And suddenly, all that is cut.
Reflect of who is a newborn. A newborn unit is a very small baby. They can't do anything for themselves. So they are 100% dependent on people around them, their parents and the health workforce. The health workforce is the nurse who spends 24/7 with that baby. The mom, unfortunately, we don't have family-centered care in our setting. So the mom will come in every 2-3 hours, feed the baby and go away. But a lot of the times, it's the nurse who is left with that baby. And they also have very many demanding roles. If you think of a sick newborn, then a lot of them will probably be on oxygen. They have an IV fluid. They need a drug to be given to them. They need to be changed. They need to be turned. They need to be fed. And all those things are dependent on someone. And that person is the nurse.
It was on a weekend, so we had reported 2 nurses on that particular shift. So there was a baby who was stable and the mother was sick, so it is the nurse who was supposed to help in feeding that baby. So the capacity was about 50, so one nurse was allocated to take care of 25 babies. So by the time it was almost feeding time, I was preparing to go and feed that baby. There was a baby in the critical ward who collapsed. So because we were 2, I had to assist my colleague to help and resuscitate that baby. So I remember we resuscitated that baby for almost like 1 hour, resuscitating and settling the baby. So by the time I went back to check on the baby to feed, we were about almost like 2 hours late. So the baby had started convulsing. When we checked the blood sugar, it was low, let me say hypoglycemia. And it was because of the delayed feeding, which was due to the staff shortage.
when you have so many babies to look at, then you don't have this time. You feel pressured. You really feel pressured. Even at a point, you can say you just stand still and now see, here, Grace, may God grace take over, and now give me whom will I prioritize. Yeah, you feel so pressured. Going home, you feel burnout.
The workforce shortage, and particularly for nurses, it's an urgent problem. We cannot assume that it's business as usual because, there's still someone who shows through the door and provides care. There's someone who is paying the price, as I said. It could be the patient, that we lose them, unfortunately. It could be, the nurse themselves. It could be the system. So it's urgent because there's a lot of momentum towards building better hospitals, giving better equipment, making sure the medication is there. But who's going to deliver the care? I think the example I always like giving is, if you have 2 babies that need to be resuscitated and there's only 1 nurse, really, you can only resuscitate that 1 baby. So we need our leadership to recognize that staffing is critical. If you don't have people to, it's like a government investing in fighter jets and not having fighter pilots. Really, the enemy will still crush you. So it's the same thing. We can't build hospitals by equipment and not have nurses.
If we want babies to get the treatment that we know they should get, and that in many places now they have equipment so they can give it, then this is the major problem now at the moment. It's the one thing that will make a massive difference, in my opinion, to whether some of these babies survive, or whether some of these babies survive without long-term problems. So for me, it's probably the most important issue to solve in providing neonatal care now. The next most important would be actually the places where the babies are looked after. They need to be better. The places do not help the nurses. They're too cramped, they're not well designed, it's very difficult to maintain infection control. So solving the nursing problem is critical, and then we need to make the environment better. And for me, because we're getting the technologies and other resources to some degree.
So one of the other things that we observed is the physical infrastructure and layout of the newborn units and how that affects how care is provided. For example, some of the babies, how the newborn unit is set up, which ideally should be in a setting that the clinicians are in a position to observe the babies from where they are sitting, for example, at the nursing station. And that's why you notice most of them have either glass walls or partitions, but also privacy in terms of a mother that is, for example, if a mother needs to ask confidential questions to the clinicians, there needs to be a space where they are able to sit down with a clinician in a private section of the unit and ask questions or receive counseling if need be. But also some of the interventions that the babies receive in these newborn units, for example, a baby has stopped breathing and needs to have a resuscitation. Ideally, that should be in a setting that is away from the glare of everybody else in the unit, because that sometimes is very scaring for the people who are not clinically trained. And so setting up the unit in a way that areas like the resuscitation area is not in the direct view of everybody, to give them the patient and their family, the baby and their family, the privacy that is needed, but also setting it in a way that is easy to clean, easy to move around, to direct patient flows, so that the way we set up where our hand hygiene stations are should really be on the way, for example, where the person is entering, so that hand hygiene compliance can go up. So that kind of just thinking through how a ward is set is one of the things that we are really recommending moving forward.
So beyond improving the clinical workforce, and it's important that also the environment and the infrastructure is looked at so that we can also help us improve care. And among those ones is to see that where the newborn unit is located is very close to the labor ward and also the postnatal ward. This will allow for easy transfer of the babies from the labor ward to the newborn unit, and the ease of the mothers to move from their wards to the newborn unit to be able to take care of the baby.
In a shift where one nurse is taking care of up to 37 babies, it becomes difficult for the nurse to focus on those tasks that require soft skills. And most important is the communication and the psychosocial support to the mothers. Within those settings and within those working conditions, it's possible then for the nurses to pay attention to the clinical aspects of care. So things like providing medication and treatment and documentation tend to take the forefront. And by the time the 12-hour shift is over, they don't have time to then spend talking as required to the mothers. And therefore, the communication and the psychosocial aspect of care then gets left behind. Not because they intend to, but because of the work pressures and the nurse-to-baby ratios and the high workload that they have.
Kindu kia mbere kiria ndambire ndaingira murango-ini wa mbere nurse uria ndakorire ambire.
When I got to the door of the newborn unit, the nurse shouted at me, apparently because I was carrying the urinary catheter wrongly. But I did not know how I was supposed to carry it since no one had told me how to. I went back crying. I even thought about leaving my baby at the hospital and going away. I also remember she grabbed my breast saying it has milk, demanding I should express.
Kama amenishika matiti, ananiambia hapa kuna maziwa, furuta.
The first gap for me was that preparation before experiencing a preterm birth. Like, especially for young first-time moms who don't know what prematurity is, don't know how a preterm baby looks like, doesn't know the process, has never been to the NBU or the NICU, doesn't know how an incubator looks like, all the noise that happens there. That is a good opportunity to educate mothers about what to expect, because you can be able to tell this is going to be a preterm birth. Even just take them for a stroll at the NICU, for them to see other babies and for them to get a feel of the whole journey ahead. It's good preparation, because that shocker you get to experience, it takes you back, it breaks you. It's at the time the nurses are asking for milk, you're so stressed, you're crying all the time. Where is that milk coming from? You can't even eat or sleep well, you know.
Most of the time, nurses are seen like they are inhuman, and it's because they've seen it all. You know, when a mom comes, tunataka maziwa, just go and express. She have never expressed. She was not expecting it. She has never been taught, and you don't have time to teach her. Then how do you help her produce that milk and express that milk that you need for her baby? You know, the milk is not yours, it's for the baby. But if you don't manage her emotions as well, you don't manage her fear, you don't help her do that, she will not give you the milk. The baby will not improve. You will not administer drugs like caffeine citrate, because you need to administer with something in the stomach. So the respiratory distress will continue. You are stressed, the mother is stressed, the baby is stressed, everybody is stressed.
So to address the issues of dignity and communication within the newborn units, what we've tried to do is sort of build a communication and management training targeted at the newborn unit nurses. So what we've tried to do is feedback some of the findings from the mother's perspectives into that communication training. So at the introduction, or the first phase of that study, is just to sort of create awareness that for mothers, these are the realities when they end up in the newborn unit. These are the worries, these are the concerns that they have. So as a healthcare provider, you might think that they're not listening to you, but that issues on the background, issues on the back end that sort of contributing to what they're doing or how they're acting when they're in the newborn unit. So just raising awareness that as healthcare providers acknowledge that the mothers are undergoing through a lot of pressure and think through how can we better support them.
After the communication skill was taught, I have less cases with relatives, less cases with what we call the political team. I have less cases with person to person, staff to staff. And they also taught in that course how to solve problems, problem solving techniques and how to calm down, how to step back, wait for your emotions to go down. Because when I abuse you, your emotions also go up and you can answer without thinking and later you are sorry. But when they learn the skills of stepping back, either by keeping quiet or walking out of the space for some time and then come later to address it when you are calm, it has worked. I have less cases, I have less complaints. Yes, and that has been a little push, a little advantage. They also feel empowered.
The big company was looking at the medical side of it, the human resource side of it, but an important actor in all this is the mother. It's important to view them not just as people who we are offering services to, but recognizing that they're also playing an important role through their contribution to some of these interventions. They perform kangaroo mother care. They're the ones who are breastfeeding and feeding the babies, and therefore they're part and parcel of providing care to these newborns. And most importantly, when the babies get better in the newborn unit, we are sending them to the community who takes care of them once they leave the hospital. It's the mothers. And therefore to get their input and participation and sort of to support them so that by the time they're leaving the hospital, they have the skills and they're capable and confident to care for the babies post-discharge.
We realize that in many of our facilities, healthcare workers are very overstretched and we are not having families, moms and other caregivers being part of the care. They are more of passerbys, if you have to say, but you'll realize that moms or caregivers will be in hospitals with their baby and they only have one primary responsibility, that baby that is admitted in that ward. So whatever you tell them, you will realize that they can be very supportive in taking care of these babies because that is what is keeping them in the hospital. And they are attached to these babies and no one else will be a better advocate for that child more than that mom themselves.
I think we recognize that there will be need to enhance the number of nurses, number one. But number two, we wish to embrace additional help to the nurses, which is these extra health workers. And this country has a number of them now being accepted, especially in the private sector.
Our situation in the newborn unit before IQ program, we had one casual who was not trained even by the facility. He's hired by the facility, but not trained, just casual, dealing with the cleaning and everything. But after IQ came in and brought us two more ward assistants who were trained, 5-day training course on various topics in terms of IPC. IPC really picked it after they have been incorporated in the ward. Now decontamination levels, cleaning the floor, the surfaces really improved in the ward. And that's why at the end of the program, we decided to retain the IQ ward assistants just to sustain. Yeah.
I think the question of support staff or ward assistants in newborn units sometimes it's a sensitive one, sometimes it's a little bit misunderstood because of the naming of the cadre. But in our earlier work, we actually identified that, we don't have enough nurses, but also these nurses are very stretched and are also doing a lot of non-technical things that can be done, record keeping, going to billing, going to the stores. I think those are tasks that can be done by nurses can be supported to do. So we realized, because the nursing workforce challenge in Kenya and in public hospitals actually is, for lack of a better word, is a financing problem, because we have a surplus of well-trained nurses who are going out of the country every single day. And because we also acknowledge that, their budget ceilings, there's only so many nurses that the government can afford to employ, then I think as part of the HiQ work was to argue that if we provided some additional nurses, but also some additional support to this workforce, then you are relieving the existing workforce a lot of these non-technical roles, like going to the stores, cleaning, sending them to a pharmacy, helping the mom figure out their way around the unit, and some basic infection prevention skills that really, with the discussions with the ministry and nursing and the nursing council and other stakeholders, are not crossing over into the scope of nurses. So then if you have these people in the unit, then they become a support system that allows nurses to have more time to provide patient care.
The other thing that is undoing the newborn progress, the progress that we've gained in newborn, is that sometimes it's seen like it's another unit, it's another department. So you'll go and say, I've lost a nurse, so we are 8, and what is so and so work 7. The other one, they are worse than you. So it's like, it's like, if they are 10, you should be 10. But your newborn unit is a special unit. It's a special unit. The work is immense. Babies don't have the treasury or the treasure of waiting for you. They don't wait for you to think it about. It's you help me now or they die.
Some improvements that needs to be done. We need to be hired for more nurses to give specialized care to the units. Supplies need to be supplied in time, because they have to be used to take care of the units. Then staff motivation. We lack staff motivation. Most of us are not motivated because of the shortage, and you have to work long hours sometimes.
My recommendations are in newborn unit, just to work on the challenges, is to hire the neonatal nurses. Having specialized nurses that have been trained on the neonatal care can really improve the care of the baby. Yes, because they can prioritize, they have the skill, they have the knowledge, they have everything that concerns that baby.
Essentially, if we look at actually what happens to a baby, so we have people looking at what happens to a baby for 12 hours and checking if the things that should be done are done, then essentially what we can say from the findings is that only about 1/3 of all of the things that a baby should have done are actually done by a qualified nurse. And that's because they simply don't have the time. So if you imagine yourself to be a nurse starting a 12-hour shift, and you've got 24 babies to look after as your responsibility for that 12 hours, if you divided all your time up and gave each baby an equal amount of time, you would only have 30 minutes in 12 hours for one baby. And that assumes that as a nurse you take no breaks, you don't have to leave the ward for any reason, you don't have to handle an emergency or anything like that. So essentially there's so little time for a nurse to be able to devote to a baby that they can only seem to do 1/3 of the things that should be done by a professional nurse. We did also find that another 1/3 of things were done usually by a student or a mother, but the nurse didn't have time to properly supervise those nurses or mothers, or properly educate the mothers to be able to do things in a safe way.
The HiQ work was a collaboration between the Oxford University, the KEMRI-Wellcome Trust Program, and Capricorn, which is the research arm of the Kenya Pediatric Association. And the work was co-designed and conceptualized together based on a long-standing collaboration that we've had.
This is one research that is reflecting what is in the ground, the reality of what is happening. And it was done over time. It was done in the ground, not in Nairobi. It is the reality of what is happening. And I think this is the best research we've ever had in neonatal care from the time we started.
The HiQ work had different components of the work and the methods to try and understand and unpack the problem and the solution. And the reason for that is, from our experience doing previous work, is that each time you showed up with a research finding, people would say, did you think about X? So what we were trying to do is create a more comprehensive package of evidence to say, we have the numbers that say additional workforce is important and you get more care being delivered. But we also have evidence that says, actually, when you have more nurses, you also have another additional benefit. There's a nurse well-being component where nurses are feeling more relieved because they have an extra workforce to work with. People get opportunity to go and leave. And other additional pieces of work that people don't reflect on. If you don't have enough nurses, what does that mean for things like infection prevention and control? So and what does it mean for patient experiences? Like the example I've just given, that if there isn't enough of you, then patients feel almost like they are abandoned because there's no one to walk them around and have enough time to sit down and communicate with them. So it was trying to create this package to say, nursing is an investment. You don't only get extra hands on the ground. You get much more than you probably are conceptualizing. You get a much more happier workforce. You get more satisfied, happier patients and mothers and babies. You get better care outcomes. You get more care being delivered. So it's pretty much to make that argument that the return on the dollar is way more than just what we are measuring. And that helps people see things almost, for lack of a better word, in a 360-degree perspective.
From the findings, I think it's very worrying. Of course, we all agree that we are not making progress in reducing neonatal mortality as fast as we should. As of now, we have 4 years, 4 months to 2030 to get to our SDG goal, which we are not very close to. So, of course, we have to really intensify our efforts to get there. And we cannot downplay the fact that human resource, especially nursing care, plays a very huge role in our intensification efforts. So I think it's very important that all the concerned parties, the governments, all other stakeholders, we are able to provide this care or provide this human resource so that our babies can get the care they deserve. Remember, we might be working to make these newborns survive, but they will need to thrive thereafter. What's the quality of life? Even if they survive their neonatal period, let's make sure that they thrive beyond the neonatal period and have a good quality of life.
We spend a lot of energy on mechanical things in care of the baby, the machines and the new equipment, and that's good. We are aware of their role, the incubators and name it. But we must emphasize the the human resources for health. And where this is concerned for the newborn, if we don't put our finger on appropriate approaches to nursing, we will not win the war.
So we have to recognize that we need both people and skill mix. We need numbers and skill mix. And we appreciate that it's a huge toll to move from 1 to 41 to 30 to 1 to 4, which is the WHO recommendation. But I think we need to start somewhere. We need to create a roadmap that says, and work with government to say, what is reasonable within our fiscal space. Is it trying to move towards to 1 to 20, then to 1 to 15 in the next 5 years, then 1 to 12 in another 3 years. So those are the sort of conversations we need to have. We're not saying we should move everyone to 1 to 4. It would be great if it's possible. We recognize we have financial challenges. The fiscal space is very constrained, but we need to start as early as yesterday to move in that right direction.
So the HiQ research outcomes have been an eye-opener for us at the Ministry of Health. This is because we aim to reduce our newborn mortality rates and ensure that every newborn survives and thrives. With the interventions that have been recommended, we at the Ministry of Health are willing to collaborate, incorporate trainings that will be for the betterment of the newborn, people working in the newborn unit, and ensuring that the numbers, we cannot still be having 92 newborn dying every day. We believe that we can get to even less than 30 in the 4 years that we have before the 2030 goal. So it is our plea to everyone. You are an advocate when it comes to newborn health. These are people who cannot speak for themselves. So let's all be advocates in the fight to reduce our newborn mortality as a country.
It's a wake-up call to all the players in this sector, those who need to make the decisions and those the policymakers to really think and reflect and see how to address this problem. Because if this persists, it doesn't matter how complex, whether we build ultra-modern facilities, if we build those structures and there are no human resources who are competent enough to work in it, we won't achieve much.
Units needs are special needs, and they don't wait. So you help them now or you lose them.